Okay, we're going to get started. Welcome, everybody, to this library-sponsored event. We have a great author here today. Her name is Rebecca Bloom to my left. And we also have the moderator, our own, very own New York Medical community network, I would say, Dr. Deborah Viola. So I'm going to introduce the two of them, and I was just going to say my involvement is really very spontaneously. I ran into the author's daughter, whose name is Sam Bloom, who's a wonderful documentarian and writer. And she told me about her mother, and I put the two together. So I quickly read the book, and this is the book that is so great, and it's a wonderful thing to read. And I think it's every female should read, women should read it. And so let me just tell you a little bit about Rebecca. She's a graduate of Yale College and New York University School of Law. Educated on women's health, workplace and benefits advocate, storytelling coach, editor, and content strategist. So she's a busy girl and clearly has made a lot of great strides. And she's a former workplace and benefits attorney and advocates for women coast to coast. Her longest and proudest affiliation was with the Bay Area Cancer Connections, where she has served as a healthcare advocate, insurance, and workplace advisor for women fighting breast and ovarian cancer for over 27 years. Rebecca's book, When Women Get Sick, is an empowering approach for getting the support you need. Broadlift Books 2025 shares the learnings and stories, and she'll be speaking with us today. I'd also like to introduce her parents. We have Linda and Bill Ackerman sitting here, who are the proud parents, and we are just very excited to have all of them with us today. And thank you for giving us Rebecca. Okay, so we also have Dr. Viola, who is the network vice president in the Office of Research and Grants Administration, RGA, at Westchester Medical Center Health Network. The RGA functions as the Protocol Activation Committee for research proposals for investigator-initiated government agency and industry-sponsored human subject clinical trials and studies, and works closely with the IRB for human subjects protection, legal, regulatory, data security, and financial compliance. Dr. Viola's team also provides oversight for network-wide grants, management for the proposals that fund capital, educational, patient care, or community-based programs. As the lead for technology transfer, Dr. Viola drives the translation of clinical insights into patient-focused solutions by managing the hospital's intellectual property portfolio and fostering strategic industry partnerships. Prior to joining Westchester Medical Health, Dr. Viola was an associate professor, director, and co-founder of the doctoral program in health policy management and the Center for Long-Term Care Research and Policy at New York Medical College. She remains on the faculty as an adjunct associate professor of health policy and management, and she received a doctorate in economics from the graduate school at the City University of New York as a Robert E. Gallese Fellow. And during her stint at the School of Health Sciences and Practice, doing the doctoral program in the health policy and management area, is where I met her. She was my first introduction to healthcare economics, and I was blown away at her ability to teach, understanding of the discipline that I knew nothing about. And we are just so thrilled because through the years, she's had a huge impact on our school. So we're thrilled to put these two geniuses together in the same room, and can't take it away.
I wasn't feeling stressed until you did these bios, quite frankly. But good afternoon and welcome, everyone, and thank you for joining us. Especially would like to thank you, Rebecca, and the fact that you're here from California, I guess visiting mom and dad, allowed us to have this on-site capability. Generally, the book discussions are remote. And I think I'm going to take a term from your book and say we're surrounded by circles of
goodness.
Yes. And for those of you who've read the book, you know what we're talking about. For those of you who didn't have a chance studying for finals, we will explain what it is soon. I am going to ask you to summarize the book, however, because some folks have joined probably last minute. Not everyone has gotten to read it. But I'm also going to have you explain why you wrote the book in the way that you did. So here's this toolkit. I view it as this toolkit that helps women experiencing illness to navigate the complexity of the healthcare system. I've been part of an academic medical center campus my entire career. Our audience today are basically individuals who are being clinically trained or public health policy experts. How do we help them bridge the gap between clinical care, between public policy design, and these barriers that you talk about in your book, right? And so we're going to challenge them to think a little differently. But you must have experienced this, or through others, if it got you to the point of having to write this book.
So thank you so much for that. And thank you everybody for having me here. Thank you so much. Okay, that was a lot of questions. I'm going to try to, let's start with why I wrote the book, and then I'll go into the way I wrote it, and I'll kind of summarize it around the edges if that works for you. So I started my career as an employee benefits lawyer. And I'll be honest, I was trying to pay off my student loans, and I tried to choose the specialty that was least offensive to my sensibilities. I mean, I don't really know a nicer way to say it than that. I just wasn't really that interested in what the clients of big law firms concern themselves with day to day. I didn't really care about mergers and acquisitions, financial instruments, insurance litigation at the high level. It just didn't speak to me at all. So I chose this very esoteric specialty, that of employee benefits and compensation. And I really didn't, it's not that I was so thrilled by that subject matter either, but it felt the closest to human. I was a humanities major in college. I cared about complex systems and how the world organizes itself and how we think about caring for ourselves and each other inside of these increasingly complex systems, right? And our world is only getting more complicated. So I told myself that even though everybody made fun of me at the attorney teas because they really didn't understand what I did inside the firm, they just thought, which part of this billion-dollar business that we're in are you doing? You know, they didn't really even get it. But I thought, well, if I have to stay up all night, at least it has something to do with humans, human resources. So that's how I got there. And I really didn't know what I would do next, except I wanted to pay off my student loans and have a baby. That was what was really on my mind. Then my husband and I moved out to Silicon Valley for his career when we had a very small child. And it seemed like 2 minutes later, but it really was more like 2 years later, when my beautiful mom was diagnosed with breast cancer. And so my almost toddler and I came back to New York to try to care for her. And, you know, I didn't know what that was going to entail. I thought I was going to work the door. Thank you for the flowers. Really appreciate the drop off. Oh my gosh, she's going to love that scented cream. Thank you. You know, and she was great. She did great. She didn't need much of a watchdog anyway. But what I found out was the hard part was the stuff you get in the mail. How do you get a second opinion? Who do you trust when they say, well, this diagnosis is more like this than it's like that, so you should consider this protocol, not that protocol. What we usually do is this. Well, does that mean that's the only thing there is? Who do you talk to? Who do you ask? Who runs the show? Who decides? It's so complicated. And I would have to say that while things in breast cancer in particular have improved immensely in terms of survivability rates, et cetera, I think the layers of complexity have gotten actually worse. And the third-party payer system unto itself is so confounding and complicated, it's just exhausting. It turned out I knew that stuff. When she got an explanation of benefits, you know, that thing that almost anybody sees it and goes, I don't know what this means, right? A CPT code, a what? What does that mean? Is it right? Is it wrong? Why does the bill say this? This is not a bill. Oh, but it says that really scary big number. You know, all that stuff, it really gives people a headache. And more than that, it stresses people out. So I saw all of this and I thought, well, you know, when you move to Northern California, you're supposed to say Eureka, you know, gold rush. Well, I had my own Eureka. I thought, whoa, I have been gifted by staying up all night with a very strange set of skills. I can parse through all of this stuff. I know what it means. I know the questions to ask. I know how to figure it out. My very first job was writing summary plan descriptions, which is something ERISA requires. And it was like I had to take a really complicated health insurance policy and explain it in English. Well, guess what? That was really good training. So after seeing what it was like for my mom, I returned to California and I connected immediately with Bay Area Cancer Connections. It had a different name at the time, but the rebrand was good. So I marched right in and had a meeting with the executive director. And I said, look, I've got these strange skills. Would this be useful to your clients? And the woman said, are you kidding me? Because, you know, when you think about what does it mean to be a health advocate or a health navigator, there are a lot of people that get trained inside the system. There's amazing nurse practitioners, incredible social workers, wonderful people, but they know the system. What about the rest of the world? What about the workplace? What about the rest of the safety net? And what about how people connect inside their community to get the help they need? What about all the nonprofits? It's all part of the world. So I was really happy doing this work, I have to say. You know, that thing people talk about, how if you have purpose, you feel differently, you walk differently, you stand up straight. Well, I always felt that way. And I loved it. I loved the work. I was also helping writers do their books. I was a book coach. I was doing all different things while I was raising my daughters. And then something happened in this country that made me really nervous about what was going to be the future for women. You know, when I really looked at the cutbacks and the changes and the constraints on the system and just sort of the direction of things legally, I thought to myself, this might be the time to share what I've been able to share with probably thousands of women, with hopefully more than that. And by the way, when a book is in the library, you get really, think of all the people that read one book. I mean, I love libraries. You know that. I told you guys that. And that's why, right? Sharing information. It's not about the profit motive, even though the publishing industrial complex has its own issues, but it's not. It's about sharing what you know. And what I saw was, okay, this system wasn't built for women. We can talk a lot about those barriers and all of the reasons why. But I learned over time that there really were ways to make it better. There really were a set of things a person could do to set themselves up for a better health journey. And it involves incredible communication with health professionals and health systems, who, by the way, are not the bad guy at all. So
We're happy to hear that, right?
yeah, not at all, not at all. And that's, you know, I know we're going to get into that, but, you know, I really felt like to fulfill my mission and my purpose, I wanted to help more women. Simple as that.
But you chose this format.
Yes,
intentionally.
I did. And that goes to the book and what's in the book.
Right.
So the way the book is organized is it really does map a health journey. It even maps before you have an illness, how to think about who you are in the world and where you fit and where you'd go and what you'd do. a proactivity. People say, like, how can you tell people to be proactive when they don't even know what's going to happen? Well, the truth is, we live in a world where you can plan in advance, and we can talk more about that. So I felt really strongly that I wanted to do this, not just like a list of things to think about. Each chapter does have what I call tips and takeaways. And if that's all somebody reads and that's all they need, great, I'm good with that. But what I really wanted to do was illustrate a lot of these principles by sharing stories of real women who went through these journeys, just to show, first of all, it's outrageous what people go through, but also with a little creative thinking and kind of opening the right door at the right time and saying the right thing and using the right words. I wanted the stories to illuminate how that worked. And so I'll be honest, some of the agents, the publishing people, were like, what do you got to tell all these stories for? And I said, because that's how women learn. That's why. I believe that.
I want to key on that. You just said, because that's how women learn, right? You had to defend how you presented your materials already.
Yep.
But I'm gonna push into that a little bit, lean into that. So the book does, okay, let me step back. They're a group of women. We've come through a generation where we don't believe in gender differences. And as I was reading the book, it's about how women think differently, process differently, handle their emotions differently. And you make those claims and you use these vignettes. Are they stereotypes? And if they're not, why are they barriers to how we receive care?
This is my favorite question ever. No one has ever challenged me on that. So, I do believe, and I'm sure you guys have heard this, it's people are talking about it in terms of research and in terms of prescription medicine and a lot of stuff. Women are not small men. We are not small men. That said, yes, you could argue that it's a stereotype to say women are relational beings. You could say it's a stereotype to say women hold up the world and we take care of everyone. That you could say that. But I think as biases go, I mean them all positively. I think they go to the strength of women as opposed to the weakness. But, are women more empathetic, intuitive, sensitive? Could it get dangerous if I said that too many times? Sure. Yeah. I mean, I see where you're going with that. On the other hand, I think we should play to our strengths. And I believe we are great communicators. We do know how to talk about things in a 360 holistic relational way that can move the ball forward. So yeah, so sue me. But I mean, you could, but might not work out, but you could try.
Okay, but they are also barriers to care. They may be strengths, but they're barriers to care.
Oh, unquestionably. But that's why we need to talk about it, right? Especially with people who are learning to take care of women, right? Or who are shaping policy. We do need to talk about it. I mean, when you think about, a lot of people said to me, hey, everything in your book could apply to men, all the stuff you say.
Oh, yeah, and I think men
right?
should read the book.
Okay, and I do too. And not just girl dads, Hey, girl dad. But I think let's back it up. Why are women different in terms of barriers? Number one, women are more economically marginalized than men. That's going to affect their choices. It's going to affect whether they have insurance at all. It's going to affect access to care in terms of quality, in terms of wait time, so many things, right? Okay. So that's one thing. And they do tend to be underemployed or unemployed at higher rates than men too. And that can affect, hey, do I have employer provided health insurance? That's a big deal right there, right? Okay, so there's that. Then the research gap. The research gap is really the biggest problem in women's health, if you ask me, bigger than any of these other things. Because you guys all know the factoid that women weren't even studied meaningfully before 1993 because nobody made them, right? And I mean, that sounds shocking unto itself. But when you really think about that, think about it. It's not like it got better in 1994, right? Every study that we care about, that we believe in, is longitudinal, right? Unless it's so obvious after such a short time that we just go, okay, done, right? But you need that time. So how long does it take to catch up? A long time. Plus, just because it's starting to change doesn't mean that all the things that affect women more are being funded. So even though we're saying, hey, we're studying women, well, look at autoimmune diseases. 80% of the time, it's women.
Right.
Why does it take so long to get those diagnoses? Could this have been understudied? I mean, wouldn't you think? I mean, that would be one of the reasons why it's so hard to get a diagnosis, right?
Or do you think when women make certain claims about their health, they're being ignored? You talk about in the book
Of
hysteria,
course.
hangover versus man flus and man colds.
Yeah.
Right. So how do we, I mean, we're training practitioners here.
Right.
So how do we sensitize
Right.
to that?
Well, the dismissal of women's pain is not something any of us have made up. I talk in my book about the Retrievals podcast. You guys know about the Retrievals podcast? It came out of a journalist studied what happened at Yale New Haven Hospital in reproductive endocrinology. It turns out a nurse was taking the fentanyl because she had an addiction problem. And it took finding empty vials to believe the women who were saying, hey, you know, that was excruciating. Hey, this is super uncomfortable. People who have been treating women in reproductive endocrinology for years were saying things like, oh, you know, it's just a little pressure. No, that shouldn't hurt. No, it doesn't. You know, you had the fentanyl. No, you know, and that's what it took. And there's a new season too, but that's the first season. So it's the dismissal of pain, and it's baked in. And then there's the hysteria problem, which, you know, they sort of work together in a loop, don't they? And Dr. Elizabeth Coleman wrote that book, All in Her Head, and it really does take this on. It goes all the way back to the Greeks, this idea that a woman is hysterical. I mean, that word hystero means uterus. And so when you think of how cultures are built around an assumption like that, well, you just don't unravel that overnight. And I mean, look at textbooks. It's everywhere. You know, all these things have to be looked at, and we have to make progress on them. But even, I mean, there's like that, I think it was Dr. Mary Claire Haver who talked about how when she was training, they would write WW in the notes. You guys know what that stands for? Whiny woman. There it is, right? I mean, so you can see how this stuff was accepted. It was built into the system, and so we have to roll it back and really look at it if we're going to make progress.
We're getting, for those who are listening remotely, we're getting a lot of audience comments through this, right? I think a lot of agreement. A lot of women in the audience are shaking their head. So these aren't stereotypes, is what we're saying.
I don't think so. I mean, there are more and more women doctors, and that certainly helps. I mean, things are changing and things are getting better, but we have to call this stuff out.
Okay, I bought into that, although I still think everyone should read the book, and I think they should read the book before there's an illness, right? Because at the point that you are navigating through the illness, you make these points in your book. We need to have this circle of goodness. I'm going to ask you to touch on that a little bit. But you also say, you know, women shouldn't travel through their illness alone. We need to have a chief of staff. Right? We need to appoint this one person who helps manage the circle of goodness and everything that we have to go through. So I'm wondering, given some of this, I think what you shared are almost their biases and how healthcare is delivered. How do health systems react to these chief of staffs, right? These non-clinical advocates.
That's an excellent question. I was lucky enough to be asked to do a webinar on this very topic with an organization called Charcheret, and I think it's on their website. So anybody who wants to look at it, it's out there for free. Because you know how we talked in COVID times about how we need third spaces because we're so lonely and disconnected? Well, when it comes to this, we need third people. And an advocate is a third person in the room. I think most patients experience that moment when they're trying to get the information that they need from their doctor. And when they ask the questions, but then when the doctor answers, they get that patient glaze. It happens. And yeah, there are notes that they can look up in the electronic health records, but those are fraud, and we can talk about that. They really are. And I mean, there's a lot of cutting and pasting. There's a lot of AI involved. There's a lot. I mean, it's too hard. It's too many things to do. And I understand that. But yeah, this idea that a third person could be in the conversation to try to facilitate better understanding, kind of modulating some of the moods of the patient, helping them deal with the anxiety that they have. HIPAA is an easy way out of this, but I mean, there's a story in my book about HIPAA gone wrong, and we can talk about that too. But really, this doesn't need to be like that. A person can come to an appointment with a patient, and all anyone has to say is, "Are you okay with this person being in the room?" And the patient can say, "Yeah." And if your system requires a quick signature, so then a quick signature. I mean, the person has a clipboard full of stuff they have to sign anyway. They'll sign it, right? Like, that doesn't have to be a barrier to it. But more importantly, I think what's important is, a really good advocate encourages a patient to see their doctor as a partner, not as an adversary. So, when I advocate for a woman, I do not attack her doctor. I do not say, "But I read this, but I read that, and did you know this, and why aren't you looking into the clinical trials?" That's not how the conversation happens. It's more like, could I do anything to assist in this? Could I help facilitate maybe all the specialists getting involved in a conversation? Would it be helpful to you if I helped her create an email or a message inside the health records for that? Do you have time to look at the clinical trials? Would it be helpful if I sent you what I found? Listen, I'm in touch with this disease-specific organization, which has all this information. I could get it for you. Would that be helpful? Thinking about it like that, most doctors, I think, appreciate somebody helping with the lift. I mean, you guys have 15 minutes and you've got to figure out how to use it. And that's so stressful.
I'm going to jump on that partnership. You've also talked about, however, healthcare has evolved where patients are viewed as audience, right? So how does that work against or work for this partnership? It would seem like it works against it to me. And in all these, you've done advocacy, for 25 years? What would you suggest is the biggest blind spot that we have as providers and practitioners?
So I think the blind spot is how anxious the patient feels, how locked out of getting the best care and having the best experience they already feel by the time they've gotten to your office. They've been through so much red tape. Think about it. They might not have had a pre-authorization to see you in the first place. They've already been told no more times than you can believe. They might have had to wait such a long time to get to see you. You don't know any of that. You walk in, all rainbows and sunshine, and they're already like this for reasons you might not realize. And I think what's sad is a lot of patients have to be taught that you guys are not the problem, because they just see you as, sort of godlike, white coat, tag, they assume you're going to say no or tell them something they don't want to hear or disappoint them because they're so conditioned to be disappointed. And so that's one of the reasons I tell people how to be a good patient all the time. And it's be respectful, be thoughtful, say, I love your shoes. Take 2 seconds to humanize the experience. Your doctor is a human being, and there's so much going on behind the curtain and so many pressures that they're under. They're being asked to know so much. And you're probably pissed at your insurance company. You're probably not pissed at your doctor if you really think about it.
I'm gonna, yeah, that's probably true. And it may even be true when people who are medical professionals are seeking out their own care and maybe sometimes experiencing the system, right? It's very personal. It's very human. So we talk about patient experience. I know at Westchester Medical Center, we think about the human experience. So we know what we have to deal with as the employee. And we know if that experience isn't good, we're not going to make it good for our patients. How patients come into the environment does influence the care they receive, right? And I think we know this, any of us who have accompanied anyone through. So with that in mind, it's both sides. Your book does talk about, the sensitivity that we need to have as we're experiencing the illness. So how does I just want to get back to that chief of staff role. How do you know that you're picking the right person for that role? Because you have some of us have a big circle, but we might pick that person who we think is the one who's going to say, didn't you read this and why didn't you get that? Because we think that's the best strategy. So it would almost seem to me like if you have the wrong advocate, you're cooked. So how do you know?
So first of all, if you're lucky enough to be partnered, your partner may not be the best chief of staff because that person is very emotional and very nervous and very worried and very stressed and probably your chief caregiving officer, right? If we're going to, continue with that kind of parlance. I think the way you figure out the best person for the job is you think about a person with a kind of equanimity, a kind of empathy. Empathy is what's required because this is a 360 situation. And, you definitely get more bees with honey. There's no question about that. I think everybody feels like they want a champion. So in a way, you might think, I want somebody who's going to yell and scream and kick down the doors for me. But that doesn't work because we know that everybody's under enormous pressure, right? I mean, patients don't always realize that doctors are being told, this is the reimbursement we get for that. This is how much time you spend on that. These are the things that we offer because these are the things that we have, and this is how it works. And if you ask this question, you can code it that way. And patients don't know any of that. But having somebody tap their foot and jump down a person's throat when they're trying to provide care, not a good look. I agree. That said, a good person to do the paperwork and the appeals and the pushing through and the fighting with the insurance companies might be that short fuse person who can reel off a sentence really fast and knows how to do that. Although I do both jobs, I am often someone's chief of staff and I'm almost always the paperwork gal as well. And I don't yell and scream ever because the person you call at the insurance company has been trained to say to you exactly what they say to you. They're probably a decent person and they're stuck. That's how it is. I mean, I was at an event the other night where there was a speaker named Wendell Potter who writes an incredible Substack called Healthcare Uncovered. And he used to work for a big insurance company until he couldn't take it anymore, and he became a whistleblower, you know? So this is people understand that the way these companies are built, and hey, they're publicly traded. Their profit motive is sealed by the way the stock market works, right? That's how it is. I mean, if you look it up, healthcare stocks are one of the bigger sectors. I mean, that's just what it is. It's a economic engine driver, right? So you have to think about all those things. But I think, I want to talk about another question that I know you sort of alluded to there. What do you do if you don't know people like this? What if you don't know a doctor and a lawyer and an accountant and a project manager? What if that's not the way your life is? Well, a couple things. First of all, disease-specific organizations have people like me. So if you reach to them, they become part of your circle of goodness. Hospital systems, you tell me what you guys have at Westchester Medical, but I bet you have a lot. I bet you have, and so the people that you have who help people navigate, they are part of this team that I talk about drafting too. It isn't just the people on your block if you happen to live in the suburbs. It isn't just the people in your building if you happen to live in a city. It's who do you interface with and who can you connect with? Here's another interesting tidbit that I share with people all the time. Let's say you can't get the access to the doctor that you really want to see, and you have breast cancer. Go to the disease-specific organization in your community, because guess who's on the advisory board? For sure. They always are. And all of a sudden, you've got another way to get to that person.
But I bet a lot of folks will go to the internet.
Yeah.
So how do you feel about that?
I have such mixed feelings about this, and doctors do too, and for good reason. Some of my doctor friends say, please, please, just don't look up anything at all. And some say, oh, no, I love when you do that, but just ask me, don't tell me, I mean, one of the things I always tell patients is, I know you're going to do it. I know you're going to use ChatGPT. I know you're going to use the Google. I know you're going to do it. Don't do it at 2 o'clock in the morning. Just don't do that, because you've got to know what's going on. What is your brain doing to you when you do it like that? So that's one thing. That's what I say on the patient side. But then the other thing, for real, doctors have access to things that you don't. That's number one. Number two, doctors are trained to read things that you're not trained to read, right? I mean, words. Dad, remember when Nana had a scan done and they said her brain was unremarkable? And she was like, what do you mean my brain is unremarkable? Do you remember that? Well, is this working? Yeah, it is. Well, I mean, that's a good thing that her brain was found to be unremarkable, right? And that's just, that's a joke thing. But people, you see the word lesion, you lose your mind. Lesion doesn't automatically mean something terrible, right? All those things. So be careful reading your scans for that reason, but also be careful reading the studies. Consider the source. People ask me all the time, where do you look? Well, Medscape over ChatGPT, I've seen it hallucinate. I've seen it say things that I know are wrong. And then I argue with it. I go, wait, but I read this. And it goes, oh, my goodness, you're right. Oh, wow. Well, what if I did that at 2 o'clock in the morning and I was a woman under pressure with a disease? And forget it. I already flipped out. It's too late, right? So I don't love it, but I love the democratization of information. It's just when we really understand the way we get served things, when we really think about how search engine optimization works, when we think about how AI actually works, AI can be great, but it only knows what it's fed. And it doesn't say, gee, I don't know everything, but I do know this. It just goes, I do know this. So you read that and you go, oh, but it was so nice to me. I guess that's my answer, right? I mean, that's what happens. I mean, isn't it amazing how supportive ChatGPT is? Yeah. I mean, it loves you. Yeah.
We love it when it helps us do our work, and we admit that, but.
And it
right,
can, right?
yeah,
If you know what to ask it.
And it does hallucinate, and I think it is scary. I mean, I know I don't like my husband looking up every pain he feels, because he now has more diagnoses than I think a human can have. But we have a time for maybe one more question, and then we're going to throw it out to questions they may have collected. And this is where I'm supposed to ask you anything you'd like to talk about that I didn't ask you to talk about. I didn't hit on in these questions. I mean, there was a lot going on in the book, and I know we started off and I said, hey, what was the motivation and why the format you chose? And that seemed to be like, that was a lot going on in that question, but it was the simplest one we really had, right? I probably would be most interested in knowing from you. Again, you've been doing this a long time. On the surface of it, when I read the book, it was pretty straightforward. I had experienced a lot of this, caring for folks, being in this business a long time. So then I did ask someone else to read it, who felt like, I had I known all of this before, I still think I would have felt as overwhelmed. So how do we really start making this less complex? The reason it's so overwhelming is because it's so complex.
Yeah, I agree. And all of our society is so complex these days, right? Legislation, getting it passed. How do you do that? Everything takes forever. Getting a book published, everything is an industrial complex now. You could just fill in the blank industrial complex, and it is. So I agree. And being trained as a lawyer gives me a little bit of an edge in terms of not being afraid of complexity, I think. Complexity is the reason we're in business, right? So I think how do you get to that? Well, I've spent my life trying to simplify complicated things. And I think for me, part of it is, think about it metaphorically. The operative metaphor in our system, unfortunately, is more efficiency and dollars driven than it is healing driven. So I always say to myself, well, how do you deal with this mess? Well, I think for me, it's go back to the studs. What should this be about? How do you navigate a great health journey? You think about healing. You think about what's going to be the most healing. So that's why I say, if this is too much, which it is for most people, if you just draft yourself an awesome team, you can focus on the healing and let them deal with the messy mess. And that doesn't mean that I can snap my fingers and make it less complex. I mean, this requires an insane amount of patience. Whenever I work with a woman, she says, I don't know how you stand this. I don't know how you can take this. I don't know how you can keep pushing a boulder up the hill, only to know that we think this drama is going to be over on a Tuesday, and it's going to take a year and a half from that Tuesday, and it's true, it is maddening. So I think I'd be lying if I wrote a book that said, okay, if you do all these things, then it'll be perfect and it'll be simpler. But I do think if you think about the higher purpose of clearing the way, of pushing away the things that cause so much anxiety and so much strain, and just sort of walking through it, recognizing that there are going to be things that go sideways, but you at least have a team to help you deal with those things. And most of the time, appeals are a great example of this. You might say, who the heck wants to deal with that when I'm trying to heal? But you know what my answer is? You can win way more than 50% of the time. If you really stick with it and you go for more reviews and you go for an outside review, if you don't win the appeal up front, you can win it a shocking amount of the time, which only proves that if you have a team and you're not the one getting the headache, you can get there.
Okay, so some questions. It looks like there are some index cards. Thank you. Okay. All right. Oh, good. So what can physicians do differently to make the experience of a woman in the healthcare space, I presume, here better?
So physicians can buck the biases, and women physicians are already quite poised to do so, but I know some wonderful male physicians too. They can appreciate the research gap. They can say things like, we don't know this because it wasn't studied, but that doesn't mean we can't try to figure it out together. As opposed to, no, you have to do this because that's all we know. Have those conversations. If a woman gets emotional and needs to cry, let her cry. And don't write that she was hysterical or, a lot of times I see animated. They say she was animated. Well, then the next person who reads that, if anyone does, which is an if, but the next person who reads that is going to say to themselves, oh, okay, maybe she's one of those, right? Don't brand your women patients with stereotypes, right? Just don't do it. You cannot do that. And I know the constraints of a short appointment, but one of the things you can do is say, listen, it would be so great if you told me your big 3 questions that you want answered before you walk out of here. And then if you have more, we could do a telehealth appointment, or you could put them in the portal, or you could call my office and leave a message and I'll call you back while I'm driving home, or here's my cell phone, text me. Some doctors do that. And I know that there's fear in doing that, but everybody has your data anyway, guys. So there's that. But also, if you establish a respectful relationship that's really a partnership, then the patient is not going to abuse that. So we can all get around all of this bureaucracy and red tape if we work together.
There's another question here. You may have to give a little context for the story of diary.
Yeah.
So the question is, where are we now, or are there any updates with regard to HIPAA exceptions to the law?
Okay, so the story of diary, this is really, I was already writing my book, and I met Diary's mother at the theater one night, and I don't know how 2 people just connect so quickly, but at intermission, she told me the whole story of Diary, and by the end of the night, we were hugging and setting up Zoom because I wanted to put Diary's story in my book. And I'm so grateful that I had that opportunity, because the story involves HIPAA gone wrong. We talked about this before, so I'm so glad we're getting back to it. So HIPAA is designed to protect patient privacy. Okay, it's part of I think a 1985 law. And so it's an old law that doesn't exactly map reality and how people interact today. I mean, it's not 50 years old, but it's at least 35 years old. So the idea of with Cobra, I'm sorry, with HIPAA is that you can say, okay, well, what if a patient is incapacitated, either mentally or physically? What do you do then about talking to somebody else if there wasn't a form filled out that allows for it? And what the law says is, well, the doctor or whoever's caring for the patient has discretion. So discretion isn't really working always, because it depends on who's exercising it and in what context. In the case of Diary was a homeless trans woman of color who was dealing with multiple things at once, mental illness and quite a few physical problems as well. And Diary was in a shelter in Brooklyn, and Diary's mother was calling and calling and calling because she knew something wasn't right. And she was told, "We're so sorry, we can't share any information with you." And it ended in horrible tragedy. And maybe that could have been avoided. So, what's happening now? Diary's mom and I have remained super close. In fact, the day my book came out, I went to dinner with her and her other daughter. That was all I wanted to do to launch my book. So we are working together. I have connected with this incredible organization in Washington called Women's Health Advocates. And my hope is to bring Diary's mom together with advocates who are really working on these policies to change them, because that was a situation where a law designed to protect a woman patient hurt her and her family instead. It didn't work.
And we actually had a question about what policy change would most improve women's health outcomes. So part of it is just the ability to be able to share information when we need to. But could you think about another policy that, is there really one? Is there?
Well, the biggest thing is funding research.
Yeah,
I mean, like I said before, the research gap is huge, and the numbers are still not right. I mean, even though things are better, we're still spending more money on erectile dysfunction than we are on endometriosis. What? We are. So that's what we have to be looking at. We have to mobilize to prioritize things that affect women.
So that gets to, there are a question here. I know that there are a lot of highly educated women, PhDs, MDs. I know doctors don't want to go in depth with information because the general population doesn't understand it, but these patients actually want it and understand it. So now they have to argue to have a conversation about the information. So where is the balance? Because if it's not worth going into depth because most people don't understand, but doctors don't like that people look it up, what's the solution?
That is really hard, and it's a really
And
smart
you're in to
question.
kind of beg this question, right? Because you're like, it's not really, you don't do it at 2 o'clock, but then do.
Yeah, I mean, to me, this is about storytelling. This is about learning how to express complicated things in a simple way so that whoever you're talking to, you may have complicated information to impart, but could you impart it in a simple way? If the person you're talking to pushes back and says, well, this study, blah, 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 Johns Hopkins, this, that, the other, okay, then you can have that conversation. But there should be a baseline of respectful communication that expresses the complexity of the situation in an accessible way.
And I also think, the person asking the question said they know a lot of highly educated women, PhD. Any one of us who would be dealing with a care issue for ourselves, or I know even in my case, a child, you go through that period of time where you're not highly educated. You're thinking about it very differently, right? And so that gets back to the chief of staff. Like I probably would have been really well served by a chief of staff many years ago when I was dealing with my son. And at first, it's as if I knew nothing, right? And it took me grounding to say, oh my gosh, I teach at a medical college. I can pick up the phone. And I remember calling my department chair first thing, who then got me into that top doc that I wanted to see that I couldn't see. And it started to kick in, but I even had that lag in pulling on my own education, resolve, extensive network and resources. So I do think to this question a little bit, is this other part that we all need someone. It doesn't matter our level of education. And I also think that we have to make ourselves available to others. And we don't always do that, right? We're so busy, and I could be as guilty as bringing a lasagna. It's in your book, right? So circles of goodness, the reason the chief of staff is how many trays of lasagna, and you talked about this earlier, do you need someone bringing to your home when you're sick? You need one or maybe none because no one in your family eats it, right? So likewise, what help can we offer? Ask, what do you need me to do? Right? And I do think that we just forget sometimes the simplest things to help each other, right?
I think that's right. And one of the things I've learned from patients is they don't always know what to do with the mental load. If you say, I'm here for you, whatever you need. They don't know what to do. It's almost for them, they appreciate it when you say, you know what, I'm just going to grab the laundry. I'm going to take it to my house. I'm going to do it. I'm going to bring it back folded. Or what I do is I just say, I got you a notebook and now I'm going to get all the paperwork and I'm taking it to my house and I'm putting it in the notebook and I'm organizing it all. And if anything doesn't look right, I'm going to take care of it for you. And that's what I say, that's what I want to offer you. If you tell them something like that, it's also like the modesty, oh no, thank you. They're like, wow, that's great. If that's something I can really use. And also learn to take no for an answer. If they say, no, I don't need that, my partner wants to do that, he's type A. Okay, that's okay too. But that specificity is actually helpful.
Someone here asked, why do you think there's such a difference in healthcare when women get sick compared to men getting sick? And I think we touched a lot on that in this conversation, but it also kind of gets back to my blind spot question. So in this case, what do you think is still the number one contributing factor? I mean, is it generational? Is it being mitigated somewhat with the new, the folks we're recently graduating, whether it's from the public policy school or the medical school? Do you see those differences?
I think it is being mitigated. I do. I think young medical students, young Ph.D. students, public health students are much more keyed into these things than their predecessors. I still think we need laws that say certain things should be taught in these schools because, again, I mentioned how long it takes to pass laws, and they're always reactive as opposed to proactive, right? So, this is stuff that should happen. We should all know about menopause. We should all understand that most cancers involve mental health issues, all these things that are, pretty simple, but it's so hard when you're being asked to be an expert in so many siloed specific things. That's one of the things I'd say. But I still think I got to go back to the research gap. What we don't know is usually the reason. Let's say, for example, a woman's taking a specific medication that's tried and true, but it's never been studied in terms of, it's been studied 25 years ago, and now we know more about the disease that she has. Well, maybe the studies weren't specific to the specific kinds of the disease that she has, and that's a reason we don't know too. And what is that about? It's the research gap again.
I will tell you one of the things that we're sensitive to here on this campus is enrolling in trials, a heterogeneous group of people. And we actually track that. Diversity in trial enrollment, totally hear you. I mean, it wasn't too long ago that most trial participants were white males of a certain age.
Right.
So that part, we also see some big changes, and the FDA guidance came out on that a couple of years ago. So I agree with you on the research, totally. And probably the other area as well is it gets back to some of those stereotypes. So having to affirm that stereotypes exist for a reason maybe sometimes there's some truth, and that's, I think, what you shout out in your book. Again, to me, it was a little startling to read because we came from a time where, we were saying that there weren't differences. We were trying to be agnostic to all of that. So that was, for me, probably one of the biggest eye-openers in reading your book. We have time. I'm going to close for one last question. I got the light dim. What gives you hope? What emerging changes give you hope?
I actually have so much hope because look at us all in this room. We're having this conversation, and women all over the country are having these conversations. And it's not just from one sector, it's the medical systems, it's the insurance companies. They're starting to care about patient experience and women's experience. It's the startup ecosystem really taking on problems that haven't been taken on the traditional ways. There's people starting to recognize that women's health is an opportunity in so many ways. Women's health centers are opening all over the place. Things are changing for the better. And when you look at menopause, I mean, maybe it's just me. Maybe I'm just getting served all the time because I am a woman of a certain age. But the conversations are being elevated, and they're also being publicized. They're being shared. And yeah, there's a lot of influencer culture stuff, and maybe not all of it's great. And sure, there are people with profit motives too. But at its core, we're realizing that this is now part of the zeitgeist. And we used to not talk about it at all. So that's really my main reason for hope. But it's also it's young medical students. It's schools like this. It's people like you. I mean, we're here because we care about women's health, and we recognize that there are so many things that have not been addressed that must be addressed. And you could say, who could do anything in a political climate like this? How are we going to make any progress? Well, guess what? We are making progress because really, it's not political.
There are women in both parties.
There are.
Thank you. This was really great. Thank you, everyone, for joining us.
Thank you so much.